Hi, everyone. Good evening. It's right at 7, so we'll go ahead and start. I'm Dr. Marjan Farid. This is my colleague, Dr. Sameh Mosaed. We're both cataract surgeons here at Gavin Herbert Eye Institute, and we're going to go over everything related to cataracts, or cataract surgery anyways. And certainly we're open to answering questions if you have. I see some familiar faces. So we'll keep it open and we'll go back and forth. We have a few slides set up to go over some of the basics, some of the newer technology that's available in cataract surgery, which may be appropriate for some patients, but not for every patient. You know, every patient is an individual and different. And we'll go over things like glaucoma in the setting of cataract surgery and how that plays a role in everything. So we'll go from there. Okay. So here's a quick picture of the eye, the anatomy of the eye. A lot of patients say, well, what is a cataract? The cataract is essentially the lens in the eye that gets opacified over time. I say it's like gray hair. Everybody gets gray hair and everybody's going to get a cataract. It's a normal process of aging where the lens gets hazy with time, starts by getting stiffer, and then over time it gets a little cloudy. It can turn a little brown. It can turn dark. It can cause glare at night when you drive. And so it's this lens in the eye right here that you see, sort of sitting in the middle of the eye. And in 90% of cases, it's a consequence of aging. Other things can cause cataracts to progress a little more rapidly, things like diabetes, trauma to the eyes, medications like steroids. So, sometimes we'll see patients who are in their 20s and 30s. Sometimes we'll see babies with cataract surgery. Those are with cataracts, and that's congenital. So we see cataracts in all ages, but in the majority, it's as a consequence of the natural aging process. And there are different types of cataract depending on the location within the lens. It could be small and located to the back of the lens. It could be the entire lens. And so, some of these different types of cataracts will cause different types of symptoms as well. Some cause more glare, some cause more of a darkening of the vision, and so on. So blurring of vision, glare, decreasing to contrast sensitivity is a big one. So, if patients are doing a lot of night driving, we want to address the cataracts sooner before symptoms become more intense. And the glasses prescription can change rapidly as the cataract starts to develop and change. So you'll go in and 6 months later, the glasses don't work anymore. That could be because the cataract is starting to progress. All right, so what do we do? So cataract surgery, probably the most common surgery performed in the United States. Actually, that doesn't work. In most cases, we do this under topical anesthesia. So we don't put patients to sleep because the surgery takes somewhere between 6 and 15 minutes. So we don't need general anesthesia. We numb the eye, give a little relaxation, IV sedation medication, and patients can go home the same day. I always tell my patients you need a driver to bring you because you get a little loopy with that sedation we give you, so we don't want you driving under the influence. And we don't use general anesthesia in general unless it's a baby or a child undergoing surgery, or if patient has a severe tremor or claustrophobia. So in select cases, we may resort to general, but in the majority, we don't need to. Again, fairly quick surgery. Patients do not need to come off their blood thinners. So I get this question all the time, do I need to stop my Coumadin or my aspirin? For the most part, no, because it's a pretty bloodless surgery. Now, if you're doing it in a combination with glaucoma surgery, and Dr. Mosaed will go through that with you, sometimes you may need to come off blood thinners. So what we do is we make a very small incision in the cornea, and like a 2.5 millimeter incision. And through that small incision, we use what's called phacoemulsification, which is ultrasound energy, to break up the cataract and vacuum it out. And then in the place of that same capsular bag that held our natural lens or our cataract, we roll, fold, and insert a new intraocular lens that sits there. And that's where there's a lot of cool intraocular lens technology that, depending on the patient's eyes and specifics of the lifestyle, may be appropriate for some cases. So here's a really quick cataract surgery. So we made a small incision through the edge of the cornea. We're going to inject a little bit of more anesthetic medication here. All of the surgery is done through these two small incisions. We use something called Viscoelastic, which is like a gel, to maintain our space and protect the structures inside the eye. And here's that 2.5 millimeter blade. You can't feel anything during this. You're numb. We make a little opening in this bag that surrounds the cataract. There's a little capsular bag, and we make a small opening on the surface of that bag in order to be able to access that cataract, chop it up and pull it out. So this little forceps is making that round opening in the capsule. We use water fluids to kind of loosen things up in there. And you can see it's just loosening things up. And now we go in with what's called the phacoemulsification tip. And we use another instrument here, and ultrasound is applied to break up the cataract, and there's a vacuum associated with this. So as the cataract breaks up, it also gets sucked out. You can see it's like a little pie in there now. We're going to start making little pie pieces and taking out those pieces in small bits. Decades ago, the eye would have to be opened up 11 or 12 millimeters, and this whole thing would be taken out as a whole. We don't do that anymore. So you don't have to wait for your cataract to be ripe, because as you can see, it's actually easier to remove when it's softer. The more dense it gets, the harder it is to break it up into small pieces. So actually the opposite is true now. You don't have to wait for it to be ripe. I hear that all the time. Yeah, exactly. What does that mean? So they used to have to wait until the cataract was super dense so that they could make this large opening and take it out, without it breaking up.
In the early stage, it isn't super dense.
No, it's not. And here's the final little layer, we call this the cortex that's removed. So now we have a capsule, or just this bag that's empty. We're going to reform that, and inside that bag is where we insert the intraocular lens. And here's an intraocular lens that we've rolled into and placed into an injector, and we're going to put that into the eye. And you can see an assistant keeps that cornea moist so we can see through it for the entire case. And here goes an intraocular lens. We're inserting it into the capsular bag. And you can see it just unfolds and settles in right where the natural lens used to sit. So the lens position is really very physiologic because it's in the natural position that your original lens sat. And there it is. Sits there. The eye is dilated right now, so the iris is big, but the pupil comes down. Most cases don't necessarily need a suture placed at the end. These wounds are, for the most part, self-sealing. But in some cases, we do put a stitch in if it looks like the wound is a little leaky. And that stitch is removed in a week or two after the surgery. And there you have it. So that's a straightforward cataract surgery. So what about that lens? Well, there are different type of lenses that can go into the eye. There's a standard, what we call monofocal lens. These are fantastic lenses. They're nice and clear like the one you just saw, but it has one focal point. And some patients say, well, set me for distance. I like to see very clearly in the distance, and you wear reading glasses, and that's fine. And for a lot of patients who have like glaucoma or macular degeneration or various things, that's the best lens. There are some lenses that we call lifestyle lenses. These are for patients who have otherwise a perfectly healthy eye, perfect retina, perfect optic nerve, and a brain that can adapt easily. And these patients can be potentially a candidate for what we call a multifocal or extended depth of range lens. And these lenses can give distance and near so that there's less dependence on wearing glasses. We also have toric lenses. Toric lenses correct astigmatism as well. Astigmatism is when there's a little bit of a football shape to the shape of the eye instead of a round shape. And so that astigmatism is corrected with certain types of lenses. Here are some lenses, what we call lifestyle lenses. These are these multifocal or extended depth of range. They've got rings on them. So I always tell patients, you're going to see those rings at night around lights. So when it's dark out and you see a pinpoint of light, the side effect from these lenses is you usually see a little halo around lights. With the modern ones, the halos are not that bad, and most people adapt to them very quickly, but you have to be aware that that's one of the side effects. That's how the lens accomplishes what it needs to do. There's other lenses that are a little more flexible, that accomplish a little bit more range of vision. And there's toric lenses that are astigmatism correcting. You see the two little dots on the lens that tell us where the astigmatism on that lens is. We line that up with the astigmatism in your eye, and it neutralizes that. Symphony IOL is one of these. This was the sort of the newest lens in these lifestyle lenses. It was FDA approved in 2016, and it increases the depth of focus. So it gives a longer range where your vision is in focus. So if we set it for distance, it keeps things in focus up to about intermediate and large print. So without needing glasses necessarily. Yeah, so real quick, let me jump into also femtosecond laser cataract surgery. This is another innovation and sort of cool technology that we use in some patients that need cataract surgery. It uses an ultra-fast laser to perform certain parts of the cataract surgery. So some of those things that you saw me doing, the laser can do. So it can soften the lens, it can make little relaxing incisions on the cornea, again to treat astigmatism. And it can do what's called a capsulotomy. I'll just show you this video real quick. There it is. So here's the laser. This is done before the patient goes into the room. We still need to make an incision, go in and take out that cataract like I showed. But now it comes out a little bit easier because it's been pre-lasered and softened up. So it works for patients, for example, with very dense cataract. It softens the cataract so it comes out a little bit easier. And there you see it.
Why wouldn't you use that for what you do rather than just for the glaucoma?
No, we don't use this. We can use this in any cataract case. For most cataract cases, this can be used. So I use it if a patient has a very, very dense cataract and I want to reverse time a little bit and soften it up so that it takes less energy to take it out. Or I use it when I want to treat low levels of astigmatism. So I'll use a laser in some cases. That doesn't need to be used in all, but it's a good system.
Do you know by looking at it if it's a dense
Yes,
cataract?
yes. We can tell how dense it is usually by looking at it. Intraoperative aberrometry, this is another technology that we use in some cases that remeasures the power of the eye once the cataract is out. So we use intraoperative aberrometry. This is what it looks like in surgery. Cataract has already been removed, but before we put the lens in, we remeasure the eye to make sure that we're putting in the right power lens. And this is really nice for patients who have maybe a history of LASIK or something that's altered their refraction in the past, and we want to double check their prescription. So we're able to do that with this technology, which is very nice. So it refines the refractive outcomes. Real quick, post-operative regimen. So everybody goes home that night with a little clear shield over the eye. We start antibiotics, we start anti-inflammatory drops right away the day of surgery, and those are continued for several weeks after surgery. We minimize lifting for 1 to 2 weeks. No bending from the waist for prolonged periods. I have patients wear their eye shield at bedtime for the first few nights, up to a week. And then we see patients the next day. We do a pressure check, make sure everything is doing good. We'll see them a few weeks after that, and then a few months after that. All right, I am going to turn it over to my partner, Dr. Mosaed, and then we'll answer some questions at the end of that. Great.